I want to tell you about a patient of mine. His name is Robert. Robert is 74 years old, retired engineer, methodical man, the kind of person who serviced his car on schedule, changed the filters in his house on time, and assumed that if he did the same with his body, stayed active, watched what he ate, took his blood pressure medication every day, his heart would hold up just fine. And for most of his life, it did. But about 18 months ago, Robert noticed something. Stairs. Stairs that had never bothered him before started bothering him. Not dramatically, not chest pain, not the kind of thing he would call 911 for. Just a heaviness, a breathlessness that settled in somewhere around the second or third flight and took longer to clear than it used to. He mentioned it to his wife, who told him to see a doctor. He mentioned it to himself and told himself it was age, that this was just what 74 felt like, that everyone slowed down eventually. And so he said nothing. For about 6 months, he said nothing, until the day his wife essentially walked him through my office door and sat down next to him and said, "Dr. Chen, my husband thinks this is nothing. I do not." That was the beginning of Robert's story, and what we found changed the way Robert thinks about his heart forever. My name is Dr. Daniel Chen. I am a physician in internal medicine, and today I want to walk you through exactly what we found with Robert, what an echocardiogram actually shows about how a heart ages, and what the research says about what is normal aging, what is something more, and what you can actually do about it. Let us begin. Now, first, I want to tell you about the test we did, because most people have heard the word echocardiogram, but few people understand what it actually shows, or why it is one of the most informative tests available for understanding how a heart is aging. An echocardiogram, often called an echo, is an ultrasound of the heart. It uses sound waves to create real-time images and measurements of the heart's structure and function. It is non-invasive, there is no radiation, no needles, no risk. A technician places a small probe on your chest, and within about 30 to 45 minutes, your cardiologist has a detailed picture of your heart's size, the thickness of its walls, how well it pumps blood out, and crucially, how well it relaxes to fill with blood between beats. That last part, how well the heart relaxes, is the part most people have never heard about. And it is the part that turned out to be central to Robert's story. Now, let me explain how the heart works in simple terms, because this is the foundation of everything. Your heart has 4 chambers, 2 on the left, 2 on the right. The main pumping chamber, the one that pumps blood out to your entire body, is called the left ventricle. And the left ventricle does 2 things in a continuous alternating cycle. It contracts, pushing blood out to your body. This is called systole. And then it relaxes, filling with fresh blood from the lungs, ready for the next beat. This is called diastole. Now, most people have heard of systolic function, because that is what your ejection fraction measures. Ejection fraction is the percentage of blood that the left ventricle pumps out with each beat. A normal ejection fraction is 55 to 70%. And when doctors talk about heart failure, many people imagine a heart with a low ejection fraction, a heart that cannot pump properly. What far fewer people know is that there is a second type of heart problem that is equally important and actually more common in older adults. And that is diastolic dysfunction, a problem not with the pumping, but with the relaxing. Let me explain what this means and why it matters so much. After the heart pumps blood out, it needs to relax to let the next load of blood flow in from the lungs. In a young, healthy heart, this relaxation is rapid. The muscle fibers uncoil quickly. Blood rushes in, the chamber fills completely, and the heart is ready for the next beat. Efficiently, with minimal effort, But in an aging heart, particularly one that has been under the influence of years of high blood pressure or high blood sugar or other stresses, the heart muscle becomes stiffer, less compliant, less able to relax quickly. Think of the difference between a fresh rubber band that snaps back the moment you release it and an old rubber band that has been left in a drawer for years, that slowly uncurls reluctantly, taking longer to return to its original shape. That is what happens to the heart muscle with age and with the conditions that accelerate aging. When the muscle relaxes slowly, the filling of the heart is less efficient. Blood does not rush in as freely. Pressure inside the chamber rises. The left atrium, the holding chamber just above the left ventricle, has to work harder to push blood in against a stiffer wall. Over time, that increased pressure can back up into the lungs, and that is where symptoms begin. Breathlessness on exertion, fatigue, the feeling that something has changed without knowing exactly what. This is called heart failure with preserved ejection fraction, or HFpEF, because the ejection fraction, the pumping function, is still normal or even elevated. It is only the diastolic relaxation, the filling phase, that is impaired. Now, age-associated changes in left ventricular diastolic function are well recognized. Decline in LV longitudinal relaxation velocities occurs as a part of healthy aging. In plain terms, some degree of diastolic change is a normal part of getting older. The heart naturally becomes slightly stiffer with age. This is not disease, this is aging. But for some people, those with high blood pressure, diabetes, obesity, or a combination of these, the stiffening goes beyond what normal aging would produce. It goes faster and further, and that is what Robert's echo showed. Robert's ejection fraction was normal. His heart was pumping beautifully, but the diastolic measurements, the measurements of how well his heart relaxed and filled, were showing changes that were beyond what you would expect for a healthy 74-year-old. His cardiologist used a specific phrase that stayed with Robert. She said, "Robert, your heart is aging faster than your body." Now, I want to explain what that phrase means clinically, because I think it is important to understand rather than just be frightened by. The echocardiogram showed 3 specific findings. Let me explain each one in plain language. The first finding was increased wall thickness. The walls of Robert's left ventricle were slightly thicker than normal for his age. This is called left ventricular hypertrophy, and it happens when the heart is under sustained pressure. For years, Robert had high blood pressure and had been on medication for it. But in the years before his diagnosis, his blood pressure had not been well controlled. The heart, having to pump against high pressure year after year, responded the way any muscle responds to heavy work. It grew, it thickened. This sounds like it should be a good thing, a stronger heart. But thicker walls actually reduce the space inside the chamber. And thicker walls are stiffer walls, which makes the diastolic relaxation problem worse. Increasing age is associated with increases in relative wall thickness and LV mass to volume ratio. The second finding was impaired relaxation. The echo measures something called the E to A ratio. E represents early filling, the blood that rushes into the ventricle when it first relaxes. A represents atrial filling, the blood pushed in by the left atrium. At the end of filling, in a young healthy heart, E is much larger than A. Early filling is dominant. The relaxation is so good that most of the blood rushes in effortlessly. As we age, and as the muscle stiffens, E decreases, A increases. The atrium has to work harder to push blood into a stiffer ventricle. And in more advanced stages, the ratio flips showing that the heart is becoming progressively dependent on the atrium's muscular effort to fill properly. Robert's ratio showed impaired relaxation, not the most severe pattern, but clearly beyond normal aging for his age. The third finding was left atrial enlargement. Because the left atrium had been working harder for years, pushing blood into a stiffer ventricle, it had responded by enlarging, stretching, and a larger left atrium is a recognized marker of chronic diastolic stress, and also a recognized risk factor for developing atrial fibrillation.
An irregular heart rhythm, that itself carries stroke risk. Robert had not developed atrial fibrillation, but his cardiologist wanted him to know that it was something to monitor. Now, I want to be honest with Robert and with you about what this means and what it does not mean. What it does not mean is that Robert is about to have a heart attack or that his heart is about to fail. His pumping function is normal. His symptoms are mild. He is active. He is being monitored. What it does mean is that years of elevated blood pressure have been leaving marks on Robert's heart that an echocardiogram could see, even when Robert felt reasonably well. And it means that the decisions Robert makes now about blood pressure control, about diet, about exercise, about sodium intake will directly affect how those findings progress or stabilize, or in some areas, potentially improve. This is where I want to spend some time because I think the practical part is what you are here for. Now, the first and most important thing for Robert and for anyone with similar findings is blood pressure control. This middle-aged to early elderly population represents the critical window during which subclinical diastolic dysfunction typically emerges in the presence of cardiovascular risk factors and is the demographic group most likely to benefit from early detection and targeted preventive interventions before progression to symptomatic heart failure. The heart thickens and stiffens in response to sustained elevated blood pressure. Reduce the pressure, and you reduce the stimulus for further thickening. Studies have shown that with good blood pressure control, the heart muscle can partially reverse its hypertrophy over months to years. It does not fully normalize in many cases, but it can meaningfully improve. Robert's target, given his findings, was a systolic blood pressure, the top number, of less than 130 millimeters of mercury, not the less stringent 140 target. That was the old standard, but the tighter 130 target that current guidelines recommend for people with evidence of cardiac involvement. To achieve that, his cardiologist adjusted his medication, and Robert, for the first time, started monitoring his blood pressure at home every morning before medication and logging the numbers for his cardiologist. The second thing was sodium restriction. Robert was eating a typical diet, not extreme, not obviously salty, but with a sodium intake that his cardiologist estimated was probably around 3,000 milligrams per day or more. The target for someone with his findings is 1,500 milligrams per day or less. Robert started reading labels and was genuinely shocked by how much sodium was hiding in canned soups, packaged bread, cheese, and the deli meats he had been eating for lunch every day. Reducing sodium reduces the volume of fluid the body retains, reduces the pressure the heart has to pump against, and over time, reduces the stimulus for further cardiac remodeling. The third thing was exercise. And here I want to be specific because the type of exercise matters. For diastolic function specifically, research has found that aerobic exercise, moderate intensity, sustained, such as brisk walking, cycling, or swimming, is one of the most effective non-pharmacological interventions for improving diastolic function. The heart muscle, like any muscle, responds to the demands you place on it.
Appropriate aerobic exercise trains the heart to fill more efficiently at higher heart rates, which over time improves diastolic compliance, the ability to relax and fill even at rest. Robert started walking every day, 30 minutes, moderate pace, not a stroll, not a race, a purposeful walk where he could speak but was aware of his breathing. The fourth thing
was weight management. Robert was not dramatically overweight, but he carried some extra weight, particularly around his midsection, visceral fat. The fat stored inside the abdomen, around the organs, is metabolically active. It produces inflammatory chemicals that directly affect the heart and are associated with accelerated diastolic dysfunction. His cardiologist was honest. Even a modest weight reduction of 5 to 10% of body weight in someone with early diastolic dysfunction can produce measurable improvements in diastolic function measurements on a follow-up echocardiogram. The fifth thing was a repeat echocardiogram in 12 months to see whether the changes were progressing or stabilizing or improving. This monitoring is important because diastolic dysfunction exists on a spectrum from mild, which is very common and often produces no symptoms, to moderate, which was where Robert sat, to severe, which can progress to heart failure. With preserved ejection fraction, knowing where you are on that spectrum and tracking the direction of change is how a cardiologist guides treatment decisions. Now, I want to address something that Robert asked me that I think many of you are wondering. He said, Dr. Chen, if my ejection fraction is normal, why do I feel breathless on stairs? This is a genuinely important question. And the answer is because breathlessness on exertion is not only caused by poor pumping. When the heart does not fill efficiently at rest, it fills even less efficiently during exercise. When the heart rate rises and the filling time between beats shortens, more heart rate, less time to fill, and in a stiff ventricle, that filling time constraint means less blood gets in per beat. Less blood in means less blood out, means less oxygen delivered to the exercising muscles. And that is why you feel breathless. Even when your pumping function, your ejection fraction, looks completely normal on paper, the echo, by measuring the diastolic function, was seeing something that a simple measurement of ejection fraction would have missed entirely. Now, I want to give you something practical that applies to you, whether you have had an echocardiogram or not. Because Robert's story is not just about Robert. It is about the large number of older adults who have similar findings without knowing it, because they have never had the test or because they have been attributing their symptoms to something else. The symptoms of diastolic dysfunction are common and easy to dismiss. Breathlessness on exertion, fatigue with activity that did not used to cause it, mild ankle swelling by the end of the day, a feeling of needing to sleep more or of not recovering as quickly from activity. These are the same symptoms that many seniors attribute to simply getting older. And sometimes that attribution is correct, but sometimes, as with Robert, an echocardiogram reveals something more specific that can be monitored and addressed. So here is what I want you to do. If you have noticed breathlessness on exertion that has changed in the last year or two, or fatigue with activity that previously did not tire you, mention this specifically to your doctor. Say the words, I have noticed I get more breathless on stairs than I used to, and I want to understand whether my heart should be evaluated. Ask specifically, would an echocardiogram be appropriate for me, given my age and my risk factors? Also ask, what is my ejection fraction? If you have had an echo before, but also ask, what do the diastolic measurements show? Because many patients have had echocardiograms and been told their ejection fraction was fine and walked away reassured, without ever hearing whether the diastolic function, the relaxation, was also evaluated. Ask specifically about that. Now, let me tell you what happened with Robert. 12 months after his initial echocardiogram, after consistent blood pressure control, sodium restriction, daily walking, and modest weight reduction, he had a repeat echo. His wall thickness measurements had not increased, his diastolic measurements had not worsened, and in one specific measurement, there was a small but real improvement. His cardiologist was pleased, not ecstatic, because Robert still has the findings he has. They do not disappear. But the trajectory had changed. Instead of progressing, as these findings often do, when the underlying drivers are not addressed, they had stabilized, and in one area, improved. Robert told me, "The most important thing for me was understanding what was happening. I had been telling myself it was just age, and in a way I was right. It was partly age, but it was also something specific, with specific causes, and specific things I could do about it. Knowing that changed everything. That is why I am telling you this today, because Robert's story is not unique. The combination of aging hearts, unrecognized diastolic dysfunction, and symptoms dismissed as simply getting older is one of the most common and most under-recognized patterns in senior cardiovascular health. And you deserve to know about it before it becomes more serious, not after. I am Dr. Daniel Chen. Thank you for spending this time with me today. If Robert's story resonated with you, please share this video with someone you care about who has been climbing stairs and wondering why they are more breathless than they used to be, and who has been telling themselves it is probably just age. It might be, but it might be something worth looking at. Leave your questions in the comments. I read every one, and I will see you in the next video. Take care of yourself and take care of your heart.